So good evening, and thank you for joining us for the 8th of the 24 Environmental Medicine Training webinars. The topic of today's webinar is Assessment and Management of Other Problematic Metals in Clinical Practice, presented by Dr. David Quig. Dr. Quig received his master's degree in human nutrition from Virginia Tech and his PhD in nutritional biochemistry from the University of Illinois. He was then a postdoctoral fellow at Cornell University for 5 years prior to serving as senior cardiovascular pharmacologist with a major pharmaceutical company for 7 years. For the past 26 years, he has performed and published research pertaining to nutrition and chronic disease. He regularly gives presentations at international and national biomedical conferences. Dr. Quig is currently Vice President of Senior Scientific Support for Doctors Data, Inc., where he conducts studies pertaining to the effects of heavy metals and chemical toxicity on nutrition and metabolism, and advises medical practitioners about the interpretation of laboratory test results and treatment options for their patients.
The potential consequences of metal-on-metal total hip arthroplasty, about 200,000 of such procedures were done per year in the U.S. and in 2013 there were over 93,000 manufacturer recalls of the prosthetics. I'm sure you've seen the commercials by the ambulance chaser lawyers about, call me if you've had a metal-on-metal hip implant and I'll get you some money. All patients will have elevated serum and urine levels of cobalt and chromium if they have this procedure done. And the levels of the metal ions vary with the specific prosthetic device, the surgical precision by which it was implanted, and the activity level of the individual after getting the total hip replacement. I read this horrifying case study of a former special ops Marine who had 2 hip replacements and metal on metal, and being the Marine, once a Marine, always a Marine, he was back on his feet, he felt good, and he had a severe attack of symptoms following running a marathon. It's not advised to do such extreme exercise after getting metal on metal hip replacements for obvious reasons. And the consequences are also ion concentration and very patient specific. Some patients would be much more susceptible than others. And again, look at some of the sources here, the wonderful Mayo Medical Laboratories. Possible toxic effects in general of the combined cobalt and chromium, local tissue toxicity with necrosis, bone loss, impaired renal function, immune dysregulation, including autoimmune reactions, inflammation, hypersensitivity reactions, chromosomal damage, malignant and cellular transformations due to the reactive oxygen species formed. Cobalt is in fact a transition metal that induces and promotes the Fenton reaction and the production of the radical reactive oxygen species such as the superoxide anion and the hydroxy radical. Okay, that's weird. Okay, cobalt-specific symptoms, again, crosses over with other metals, even some of the horses. Chronic cobalt exposure, as occurs with metal on metal hip arthroplasty, just generalized skin conditions such as eczema, maybe pruritus, that extreme itching on the palms of the hands and the feet, hypothyroidism, headaches, cognitive decline, polyneuropathy. We also see bilateral polyneuropathy with arsenic. So again, is it a horse or is it a zebra? A complete loss of vision and hearing, and possibly cardiomyopathy, and that would be with extremely high levels due to major implant failure. Now, how do we assess exposure to cobalt? Circulating ion levels at which toxicities are induced remain unknown, and there is no determination of a safe circulating level of cobalt as to date. Adverse reactions to the metal, to the release of the metal, in other words, bioaccumulation, can be clinically silent and severe. So early detection is very, very important. Test your total hip replacement patients annually for at least for serum, cobalt, and chromium, and every 6 months if they have mild symptoms, and that would be like pain in the groin, pain in the hip, clicking noise, a funky feeling of the prosthetic. And again, more frequently test the serum or the urine for those metals. Serum cobalt levels normal are considered to be between 0 and zero point 0.9 nanograms per mil. But again, from the Mayo Medical Laboratories with a metal-on-metal hip implant, if the serum cobalt level is less than 10 nanograms per mil, they consider that to be an indication that the prosthetic is in good condition. Not the patient, but the prosthetic. If the serum level is between 4 and 10 nanograms per mil, that would suggest that the prosthetic was in good condition. Again, not the patient, but that the prosthetic was in good condition. And with serum levels greater than 10 nanograms per mil would suggest significant prosthetic wear. So they're really approaching this from the angle of trying to assist the orthopedist, and because when the prosthetic gets out of a line, you're going to have excessive, much more wear, much more rubbing of the metal on metal, instead of that single point of the ball rubbing in the metal socket. You're going to have the ball rubbing all around and much more extensive release of the metal into systemic circulation. Urine cobalt can be done on a random urine. Normal level is considered between 0 and about 2 micrograms per gram creatinine. Again, from the perspective of what is the condition of the prosthetic, with a metal-on-metal implant, with urine levels between 2 and 4 micrograms per gram creatinine, hey, the prosthetic's in good condition. Greater than 5 indicates wear. Well, wear, what does that mean? And with significant prosthetic wear greater than 20 micrograms per gram. And I should point out that there is what they call a grow-in period. I call it a break-in period, where during the first 3 months after receiving the metal-on-metal implant, there will be higher levels of cobalt and chromium in the serum and urine, uh, as opposed to later on if the prosthetic is in good condition. So there is this period where you're obviously, as you start to use the joint, you're going to get more release of cobalt and chromium, and then that drops off under ideal conditions um, after 3 months. But again, metal on metal implants in the body was never ever a good idea. Probably about as good of an idea as using mercury to replace holes in your teeth or to fill holes in your teeth. So when you see high levels of cobalt in the urine, do consider high dose vitamin B12 supplementation. I participate in the Autism Research Institute think tanks on an annual basis, and one year there was an MD that just raised the issue that the high dose sub-Q injections of methyl B12 that work so well in some of the autistic children was resulting in urinary excretion of cobalt that was similar to that associated with occupational exposure. Well, the problem is what we were looking at there was excretion of the methylcobalamin, not free cobalt. Because my first question to the doctor was, did they have megaloblastic anemia? That's the classic sign of cobalt toxicity. The answer was no. And when you do the analysis for cobalt in the laboratory, you're using an ICP mass spec, and it's going through, the urine is going through acid and microwave digestion, and then goes through an 8,000 degree plasma vector, and it burns up all of the organic material. And so what you're seeing is only the elemental cobalt, and in this case it was a false alarm. The methyl B12 injections are not associated with free cobalt excess in the body. So just be aware.